Have you ever thought about how the very things we rely on to keep us healthy might actually be working against us?
Hmm. Interesting thought.
Like, what if those everyday habits we think are good for us are actually setting us up for health problems down the line?
I see where you're going with this.
And what if something as simple as that extra bit of weight around our waistlines is more than just a cosmetic issue? What if it's a warning sign that something deeper is going on?
A sign of a larger issue, yeah.
That's exactly what we're diving into today on the deep dive, the often silent threat of cardiometabolic syndrome.
Definitely something that deserves more attention.
We're going to break down this complex condition so you can really understand what it is, why it's so important, and what it means for your health. We've been poring over a really detailed presentation that covers everything from the history of cardiometabolic syndrome to the latest management strategies.
Sounds comprehensive.
Our goal is to give you a crystal clear picture of what cardiometabolic syndrome is, why it matters, and what you can take away from all this information to be more informed about your own well-being.
I like it. Knowledge is power, as they say.
Before we jump in, a huge thank you to London Heartbeat's Z Academy UK for their educational support in putting this deep dive together. If you're interested in learning more about this topic and many others, definitely check out their incredible catalog of over 150 popular courses.
Wow, 150 courses. That's impressive.
And to make sure you don't miss any future deep dives or other exciting content, make sure to subscribe to their social media channels on Facebook, Instagram, and YouTube. They have a ton of free, regular updates and discussions that are definitely worth checking out. Just a heads up, this isn't your typical podcast episode.
Okay, so something a bit different.
We're doing a deep dive into this particular presentation on cardiometabolic syndrome, getting into all the nitty-gritty details, ready to unravel this whole thing.
Absolutely. Let's get started.
All right, so let's start by taking a trip back in time to see how our understanding of cardiometabolic syndrome has evolved over the years.
Yeah, it's not something that just popped up overnight. It's a condition that we've been piecing together for almost a century.
It's like a medical mystery unfolding over decades.
Exactly. And one of the earliest clues came back in 1923 from a researcher named Kylan.
Kylan, okay. What did he discover?
He started to notice a pattern. People with high blood pressure often also had high blood sugar and high uric acid levels.
Interesting. So even back then, they were seeing these connections between what we might think of as separate conditions.
Right. It was a hint that maybe these weren't isolated problems, but rather different facets of a larger issue.
Like pieces of a puzzle that hadn't been fully assembled yet.
Precisely.
Then, a little over a decade later, in 1936, we have Hemsworth's report shining a light on insulin insensitivity, particularly in the context of diabetes.
Hemsworth. His work was pivotal.
Can you give us a simple explanation of what insulin insensitivity means?
Imagine insulin as a key that unlocks your cells to let sugar in.
Okay, a key to open the door for energy.
Exactly. But in some people with diabetes, Hemsworth found that this key wasn't working as well. It's like the lock was getting rusty.
So even though they had insulin, it wasn't doing its job properly.
Right. The cells were becoming resistant to insulin's signal, so the sugar couldn't get in effectively, leading to high blood sugar levels.
I see. So it's not just about the amount of insulin you have, but also how well your body responds to it.
That's a crucial point.
This was a major step forward in understanding that not all diabetes is the same.
Absolutely. And that this idea of insulin resistance played a key role.
It seems like being able to actually measure insulin levels must have been a game changer in terms of studying this further.
You're absolutely right. A big breakthrough came in 1965 when Yellow and Burson developed the insulin assay.
The insulin assay, and what did that allow them to do?
For the first time, they could directly measure how much insulin people were producing and how that related to their blood sugar control.
So it was a way to see the actual levels, not just infer them based on symptoms.
Exactly. And what they found was fascinating. Some individuals needed to churn out way more insulin to get the same blood sugar lowering effect as others.
So even with the same amount of sugar in their blood, their bodies were handling it very differently.
Exactly. This was direct confirmation of that varying insulin sensitivity that Hemsworth had proposed.
Okay, so we've got these individual pieces of the puzzle starting to come together. Linked conditions, insulin not working properly, and now a way to actually measure insulin. But it sounds like Reevan's 1988 Banting lecture was the moment when the full picture of cardiometabolic syndrome really started to emerge. What made his work so groundbreaking?
This is where it gets really interesting. Reevan's lecture was a pivotal moment. He introduced the term Syndrome X, which is what we now often call metabolic syndrome.
Syndrome X. Okay. And what did this term encompass?
He brought together those seemingly disparate risk factors: high blood pressure, high blood sugar, unhealthy cholesterol levels,
Mm.
and said, hey, these aren't just random coincidences, they're part of a bigger picture.
He saw the connections, the pattern.
Exactly. He believed that insulin resistance was the common thread linking them all together.
So it wasn't just about treating each of these things separately. There was a need to address the underlying issue of insulin resistance.
That was his central argument. And he even later preferred the term insulin resistance syndrome to really drive that point home.
Interesting. So his work was kind of a paradigm shift in how we think about these conditions.
Definitely. It spurred a wave of research to better understand these connections.
It's amazing how a single lecture can change the course of medical thinking. It also sounds like this condition has gone by a lot of different names over the years as our understanding has evolved.
Oh yeah, it's had quite a few aliases.
Besides Syndrome X and metabolic syndrome, what are some of the other terms we might come across?
Well, you've got cardiovascular dysmetabolic syndrome, which really highlights the link between metabolic problems and heart health.
Cardiovascular dysmetabolic syndrome. Okay.
Then there's the simpler metabolic syndrome, which is pretty common. And of course, insulin resistance syndrome, which, like we said, was Reeven's preferred term.
Makes sense.
And then there's some more informal names out there, like beer belly syndrome, which emphasizes the role of abdominal fat.
Beer belly syndrome, that's pretty straightforward.
Right. Gets the point across. And sometimes you'll hear it called Reason syndrome, giving credit to his foundational work.
Okay, so lots of different names, but all pointing to the same basic concept. So let's cut through the confusion and get a clear definition. What exactly is cardiometabolic syndrome?
At its core, it's a cluster of specific risk factors that, when they occur together, significantly increase a person's risk of developing serious health problems.
So it's not one single disease, but rather a combination of things that raise your risk.
Exactly. It's like a perfect storm of metabolic abnormalities that put you on a path toward trouble.
And what kind of serious health problems are we talking about here?
The big ones are cardiovascular diseases, things like heart attacks and strokes, and also type 2 diabetes.
Heart attacks, strokes, diabetes, those are some serious concerns.
Absolutely. And that's why recognizing and managing cardiometabolic syndrome is so critical.
So it's not just about treating individual risk factors in isolation. It's about recognizing that they're interconnected and need to be tackled together.
Exactly.
So what exactly are these risk factors that make up this dangerous cluster? What do we need to be on the lookout for?
Well, there are several key components. First up, we have hypertension, which is just a fancy word for high blood pressure.
Okay, hypertension or high blood pressure, what numbers are we looking at here?
When your blood pressure readings are consistently 140 over 90 millimeters of mercury, LMNHg, or higher, that's considered hypertension.
140 over 90, got it. What's the next risk factor on the list?
Next up is dyslipidemia, which basically means you have unhealthy levels of fats or lipids in your blood.
Dyslipidemia, okay. And how does that usually show up?
It often manifests as high triglycerides.
Triglycerides, those are a type of fat found in the blood, right?
Right. And we're talking levels above 150 milligrams per deciliter, MGDL, or 1.7 millimoles per liter, IBL. And it also often involves low levels of HDL cholesterol.
HDL cholesterol, that's the good cholesterol, right?
Exactly. It helps clear out the bad cholesterol from your arteries. And when it's too low, below 35 milligl or 0.9 millimole, that's a problem.
Okay, so we've got high blood pressure, unhealthy fat levels in the blood. What else contributes to this cluster of risks?
Another key factor is central obesity, which is essentially excess fat around your waist.
Central obesity, also known as the dreaded belly fat.
You got it. And we're not just talking about overall obesity, although that's important too. This is specifically about where that fat is stored.
So it's not just how much fat you have, but also where it's located on your body. And how do we define central obesity? What are the measurements used?
There are a few different ways to measure it. One common measure is body mass index, BMI, which gives you a general idea of your weight relative to your height.
Right, BMI. Most people are familiar with that.
If your BMI is over 30 kilograms per square meter, kilogmo, that indicates obesity.
Okay, so BMI over 30 is considered obese, but you said there are other ways to measure central obesity.
Yes, because BMI doesn't tell the whole story. For central obesity, waist circumference is actually a more telling indicator.
Waist circumference. Okay, so how big does your waist need to be considered centrally obese?
Well, there are different guidelines out there. The ATP3 criteria, that stands for the National Cholesterol Education Program Adult Treatment Panel the Third, defines central obesity as a waist circumference greater than 102 centimeters, about 40 inches, for men, and greater than 88 centimeters, about 35 inches, for women. But the International Diabetes Federation, IDF, they use slightly different, often stricter cutoffs. Greater than 94 centimeters, around 37 inches, for men, and greater than 80 centimeters, around 31.5 inches, for women.
So even for something seemingly straightforward like central obesity, there are different thresholds depending on which guidelines you're using. It seems like there's not always a clear-cut answer.
That's right.
What are the other key components of cardiometabolic syndrome?
The next one is impaired glucose handling, which basically means your body is having trouble regulating blood sugar levels.
Impaired glucose handling, so it's not full-blown diabetes yet, but it's a sign that something's not quite right with how your body is processing sugar.
Exactly. And this can manifest in a few different ways. One is insulin resistance, which we've talked about.
Right, where your cells aren't responding to insulin the way they should.
Another is impaired glucose tolerance.
Impaired glucose tolerance, what does that mean?
This is when your blood sugar levels are higher than normal after eating, but not quite high enough to be diagnosed with diabetes.
So it's like a pre-diabetes stage.
You can say that.
And of course, full-blown diabetes mellitus is also a part of this component.
That's right.
Are there any specific markers that doctors look at to assess glucose handling?
Yeah, they'll look at things like your fasting plasma glucose, FPG level.
Fasting plasma glucose, okay. What's considered a red flag there?
If your FPG is consistently over 110 milli-GDL, 6.1 millimol, that's a cause for concern. And they might also do an oral glucose tolerance test.
An oral glucose tolerance test, what does that involve?
They basically give you a sugary drink and then check your blood sugar levels at specific intervals to see how your body handles the sugar. If your blood sugar 2 hours after the drink is over 200 milli-GDL, 11.1 millimol, that indicates impaired glucose tolerance.
So it's a way to see how your body responds to a sugar challenge.
Exactly. And then finally, some diagnostic criteria, particularly from the World Health Organization, WHO, includes something called microalbuminuria.
Microalbuminuria, that's a new one. What is that?
It's essentially when small amounts of albumin, a type of protein, leak into your urine.
Okay.
It can be an early sign of kidney damage, which is often linked to high blood pressure and diabetes.
So it's another piece of the puzzle that might point to cardiometabolic syndrome.
Exactly.
So to recap, we've got these 5 main areas: high blood pressure, unhealthy lipids, excess abdominal fat, problems with blood sugar regulation, and sometimes early signs of kidney issues. But to be diagnosed with cardiometabolic syndrome, do you need to have all of those factors?
That's a good question. And it actually gets a bit tricky because different organizations have slightly different criteria.
So there's not one universal definition.
Unfortunately, no. And that can be a source of confusion.
Can you walk us through the different diagnostic approaches?
Sure. The World Health Organization, WHO, for example, has a pretty specific set of criteria. They say you need to have impaired glucose handling, whether it's insulin resistance, impaired glucose tolerance, or diagnosed diabetes, plus at least 2 other risk factors. And they also specifically include microalbuminuria as a requirement.
Okay, so impaired glucose handling plus 2 other factors, and they always consider kidney function. What about other organizations?
The International Diabetes Federation, IDF, has a slightly different approach. They require central obesity as a must-have, along with any 2 of the other metabolic abnormalities.
So central obesity is non-negotiable for them.
Right. And then there's the NCP ATP3 criteria, which say you need at least 3 out of 5 of the risk factors we've discussed.
3 out of 5, so it's a bit more flexible.
Yeah. So you can see how it gets a bit messy, with different groups having slightly different thresholds for diagnosis.
It definitely underscores the complexity of this condition and how it's not always a simple black and white diagnosis. Now, zooming out a bit, we hear a lot about global cardiometabolic risk. What does that really mean, and how big of an issue is this on a worldwide scale?
Global cardiometabolic risk is essentially a measure of your overall likelihood of developing either type 2 diabetes or cardiovascular disease, like a heart attack or stroke, in your lifetime.
So it's looking at your overall risk, not just for one specific condition.
Exactly. And this risk comes from a whole bunch of different factors, some that we can change the modifiable risk factors and some that we can't.
So it's a combination of our genetics, lifestyle, and environmental factors.
Right.
Can you give us some examples of these modifiable risk factors? What are the things that we have some control over?
Well, some of the classic ones are smoking, high LDL cholesterol, which is the bad cholesterol, high blood pressure, and high blood sugar levels.
Okay, so those are things that we can definitely work on through lifestyle changes or medications. What about some of the newer or emerging risk factors?
Those tend to be more closely linked to how much fat you have, particularly in your abdominal region.
So again, it's not just about overall body fat, but specifically about the fat stored around the organs in your belly.
That's right. And those emerging risk factors include insulin resistance, low HDL cholesterol, the good cholesterol that helps clear out the bad stuff, high triglycerides, and also increased inflammation throughout the body.
Okay, so a lot of these risk factors are things we've already talked about. But it sounds like it's not just about having one or two of them, it's about the combined impact of several. It's like a domino effect, right?
Exactly. The more these risk factors you have, the greater your overall cardiometabolic risk becomes. And it's not just a yes or no thing, it's more like a spectrum.
A spectrum of risk, I see. And sadly, even with all the medical advancements we've made, cardiovascular disease remains a leading cause of death worldwide.
Sadly, it's true. It's still a major public health challenge.
Do you have any statistics that illustrate just how big of a problem this is?
Well, looking at data from the United States back in 2002, we can see that heart disease and stroke were responsible for far more deaths than other leading causes like cancer, accidents, lung diseases, and even diabetes itself.
Wow, that's really sobering. And it's not just about people who haven't been diagnosed or aren't receiving treatment. Even people who are being treated for some of these risk factors can still be at significant risk of having a heart attack or stroke. Right.
Absolutely. That's a really crucial point. The heart protection study, a large clinical trial, looked at patients who were already taking statins, which are medications to lower LDL cholesterol.
So they were already on medication to manage one of their risk factors.
Right. And despite this treatment, almost 20% of those patients still had a major cardiovascular event, like a heart attack or stroke, within 5 years.
Wow, that's a significant number. So it really highlights that even if you're managing one aspect of your cardiometabolic health, there might still be underlying risks that need to be addressed.
That's exactly it. It points to the importance of a more comprehensive approach, looking at all those risk factors together rather than just focusing on one.
So it's about looking at the whole picture, the whole system. Now, shifting our focus to abdominal obesity, which seems to be a key player in this whole scenario, just how widespread is this issue globally?
Unfortunately, abdominal obesity has reached epidemic proportions around the world.
Epidemic proportions, wow.
It really is a global health crisis. And while the exact numbers vary depending on the region and even between men and women, the overall trend is worrisome.
Can you give us some examples of those prevalence rates, just to give us an idea of the scale of this problem?
Sure. In the U.S., back in the early 2000s, data showed that about 37% of men and 55% of women had abdominal obesity.
More than half of women, that's significant.
It is. And in Southern Europe, the numbers were around 33% for men and 44% for women.
Still very high. What about other parts of the world?
In South Korea, there was a big difference between the genders, with about 21% of men and 42% of women affected. And in Australia, it was around 27% for men and 34% for women.
So it really is a global issue.
Yeah. And even in South Africa, which had relatively low rates in men, around 9%, it was still 42% in women. And Northern Europe wasn't far behind, at 23% for men and 26% for women.
Wow, those numbers are really eye-opening. It makes it clear that abdominal obesity isn't just a problem in one specific part of the world.
It's definitely a worldwide health challenge.
Let's dive deeper into abdominal obesity. We've mentioned it's defined by waist circumference. Can you explain why the location of fat in our body seems to matter so much?
It's not just about how much fat you carry, but also where it's stored that affects your health. And abdominal obesity is particularly problematic.
Okay, so it's not just subcutaneous fat, the stuff you can pinch. There are different types of fat in our bodies, right?
That's right. You've got subcutaneous fat, which is right under the skin. But then there's also fat stored within your muscles, in your liver, and deep inside your abdomen surrounding your organs.
Okay, different fat compartments. And which one is the real troublemaker?
It's the fat deep inside your abdomen, called visceral fat, that's the most worrisome.
Visceral fat. So that's the fat that's packed around your organs, like your liver and intestines.
Exactly. And it's not just sitting there passively. It's actually very metabolically active, almost like a little factory churning out harmful substances.
A factory of trouble, basically. What makes this visceral fat so much more dangerous than the fat we have elsewhere? What kind of havoc is it wreaking?
One of the main problems is that it releases a lot of free fatty acids, FFAs, into your bloodstream. And these FFAs go straight to your liver, which is a key player in regulating your metabolism.
Okay, so it's messing with liver function. What else does it do?
Well, this flood of FFAs can make your liver and muscles resistant to insulin, which, as we've talked about, is crucial for controlling blood sugar levels. And it also messes up your cholesterol levels, raising your triglycerides and lowering your HDL cholesterol.
So it's a triple whammy, disrupting liver function, contributing to insulin resistance, and throwing off your cholesterol levels.
Right. And to make matters worse, visceral fat also pumps out all these inflammatory molecules.
So it's causing inflammation throughout your body.
Exactly. And that chronic low-grade inflammation is linked to all sorts of problems. Insulin resistance, problems with your blood vessels, and even the buildup of plaque in your arteries, which is a major contributor to heart disease.
Wow, it's like a chain reaction of negativity. And what about leptin? Didn't you mention that earlier?
Leptin is a hormone that's supposed to help regulate your appetite.
Right, it tells your brain when you're full.
But with abdominal obesity, you often have high levels of leptin, but your body becomes resistant to its signals. So you keep eating, even though you should be feeling full.
That's frustrating. It's like your body's own signals are getting ignored. So are there any other ways that visceral fat wreaks havoc?
Oh yeah, it doesn't stop there. It also increases the production of things that make your blood more likely to clot.
Increasing the risk of blood clots. That's scary.
It is. And to top it all off, it even messes with your blood pressure by increasing the production of a hormone called angiotensin II.
So it's really like a ticking time bomb, setting the stage for a whole cascade of problems. And it's no wonder that people with abdominal obesity often have other cardiovascular risk factors as well.
That's right. It's very rare to see abdominal obesity in isolation. It often comes with a whole package of other issues.
Based on those NCP ATP3 criteria we talked about, what are some of the other risk factors that often accompany abdominal obesity?
Well, we've already touched on a lot of them. High LDL cholesterol, high triglycerides, low HDL cholesterol, high blood pressure, and high fasting glucose. It's like a whole metabolic gang hanging out together.
Metabolic gang, I like that. And just how common is it to have multiple risk factors along with abdominal obesity?
Studies have shown that a whopping 86% of people with abdominal obesity have at least one other component of metabolic syndrome, and about 24% have two or more.
So it's not just an isolated issue. It's often part of a bigger, more complex picture. And the research really does connect abdominal obesity directly to a higher risk of having a heart attack or stroke, doesn't it?
Absolutely. There's a ton of research that shows this link very clearly.
Can you give us an example of a study that really highlights this connection?
Sure. The HOPE study, that's the Heart Outcomes Prevention Evaluation, showed a strong correlation between a larger waist circumference and a higher risk of dying from cardiovascular disease, having a heart attack, or even dying from any cause. And that's even after taking into account other risk factors like BMI, age, smoking, and whether they already had heart problems or diabetes.
So it's not just that these people might have other risk factors. The waist circumference itself seems to be an independent predictor of risk.
That's right. It adds an extra layer of risk on top of everything else.
Is there any research that specifically links abdominal obesity to diabetes?
Definitely. A study back in 1997, Carrie et al., showed that the bigger your waist circumference, the higher your risk of developing type 2 diabetes.
That's not surprising given what we've learned about insulin resistance and how visceral fat contributes to that.
Exactly.
And there's research on women specifically, right? Showing that waist circumference is a strong predictor of heart disease, even after taking into account other factors like BMI.
That's right. A study by Rexroad et al. In 1998 found that waist circumference was an independent risk factor for coronary heart disease in women.
So it really drives home the point that where you carry your fat matters, and that abdominal obesity is a serious red flag. Now, we've been talking a lot about these metabolic abnormalities, high blood pressure, unhealthy lipids, insulin resistance, and so on. But these issues don't just exist in a vacuum. They trigger a cascade of other health problems. What are some of the other linked metabolic issues, and what kind of domino effect do they have?
Well, we've already discussed impaired glucose handling and insulin resistance,
No.
as well as dyslipidemia, which is that combination of high triglycerides and low HDL cholesterol. But there's more to it. Cardiometabolic syndrome often involves problems with your blood vessels, a tendency for blood clots to form, and even changes in how your blood flows.
So it's disrupting the whole circulatory system.
Exactly.
Yeah.
And then there's the chronic inflammation we talked about earlier, which can have widespread effects throughout your body.
Chronic inflammation, a silent but dangerous force.
Exactly. And for women specifically, Cardiometabolic syndrome is often linked to excess testosterone production from the ovaries, which is tied to polycystic ovary syndrome, PCOS.
PCOS, yeah, that can have a whole range of effects on a woman's health and hormones.
Right, and even sleep disorders like sleep apnea are commonly found in people with cardiometabolic syndrome.
Sleep apnea, so their sleep is being disrupted too. It sounds like a perfect storm brewing.
It is, and all of these metabolic disturbances increase your risk of developing a whole bunch of chronic conditions.
So, what are some of the specific conditions that are linked to this cascade of metabolic issues?
Well, there's type 2 diabetes, which we've already talked about extensively,
That's a major concern.
and then there's essential hypertension, which basically means high blood pressure that doesn't have another obvious cause.
Okay, so persistent high blood pressure. What else?
In women, like we mentioned, there's PCOS, and then there's non-alcoholic fatty liver disease, NAFLD, where fat builds up in your liver. And of course, sleep apnea, which can have all sorts of consequences on its own.
So, we're seeing problems with blood sugar regulation, blood pressure, liver function, sleep. It really is a whole body issue.
It is, and it doesn't stop there. All of these metabolic abnormalities dramatically increase your risk of developing heart disease.
Heart disease in its various forms, right?
Right. That includes things like heart attacks, peripheral vascular disease, which affects the blood vessels in your limbs, and strokes.
Wow, that's a sobering list. And I've also heard that there's a connection between cardiometabolic syndrome and some types of cancer.
There's definitely a growing body of research pointing to that link. It seems like cardiometabolic syndrome might increase your risk of certain cancers, including breast, prostate, colorectal, and liver cancer.
So it really underscores that this is not just a collection of minor issues. It's a cluster of problems with potentially serious long-term consequences. And given this complex web of interconnected risk factors, managing them effectively seems like it would require a multi-pronged approach. What are the key aspects of managing all these different risk factors in someone with cardiometabolic syndrome?
The most important thing is to tackle these risk factors together, not in isolation.
A holistic approach, I see.
Exactly. That means actively managing things like obesity, glucose intolerance or insulin resistance, dyslipidemia, and hypertension. It's not just about treating one symptom or condition. It's about addressing the whole underlying problem.
Makes sense. And what's the ultimate goal of this comprehensive management?
The ultimate goal is to reduce the risk of developing type 2 diabetes and cardiovascular disease in the long run. It's about preventing those serious, life-altering consequences.
Prevention is always better than cure, right?
Uh-huh.
So, are there specific targets that healthcare professionals aim for when managing these individual risk factors?
Yes, there are. And these targets can vary slightly, depending on the specific guidelines being used, whether it's from the IDF, the WHO, the ATP3, or the American Diabetes Association, ADA.
Right. We've talked about how different organizations have slightly different approaches. So, can you give us some examples of these targets just to get a general idea?
Sure. For glucose abnormalities, the IDF and the ADA generally recommend keeping your fasting plasma glucose, FPG, under 100 mg/dL, 5.6 mg/dL. And the WHO's criteria for diagnosing diabetes is a fasting glucose of 126 mg/dL or higher, or a 2-hour post-glucose load of 200 mg/dL or higher, or an HbA1c of 6.5% or higher.
Okay, so different organizations, slightly different numbers, but all with the same goal of keeping blood sugar levels within a healthy range.
Exactly.
And what about blood pressure targets?
The IDF suggests aiming for less than 185 mg/Hg for people with metabolic syndrome or diabetes. The WHO uses 190 mg/Hg as the cutoff for hypertension. And the NCEP ATP3 guidelines recommend getting your blood pressure below 130/80 mg/Hg if you're at high risk for heart problems, which often includes people with metabolic syndrome.
Got it. So again, the exact numbers vary slightly, but the goal is to keep your blood pressure under control.
Have you ever noticed those little signs your body sends? Like, when you feel out of breath a little too easily, or maybe you just can't seem to shake that extra inch around your middle? Or what about when you crave sugary snacks after every meal? Ever wonder if those are just random things, or if they're trying to tell you something deeper?
Well, what if those subtle cues are actually pieces of a larger puzzle? What if they're hinting at something going on beneath the surface, something that affects your overall health in a big way?
Today, we're going to unlock that puzzle.
We're diving deep into something called cardiometabolic syndrome.
It's a term you might have heard, but might not fully understand.
We'll break it down, no jargon, just straight talk. We'll cover what it is, the different ways experts define it, and why it matters so much for your well-being.
And the best part? We're going to arm you with knowledge, real, actionable steps you can take.
Think of this as your roadmap to a healthier future. A future where you feel amazing and stay healthy for the long haul.
A big shout out to London Heartbeats Z Academy in the UK for their awesome support in making this kind of educational deep dive possible.
If you love learning and want to explore more than 150 popular courses they offer, be sure to hop on their social media. You'll find them on Facebook, Instagram, and YouTube. Subscribe to their channels for regular updates. It's all free, and you won't want to miss their incredible discussions.
So, ready for your mission? Today's all about demystifying cardiometabolic syndrome.
We'll dissect those different definitions, pinpoint those individual risk factors, see how common this is around the world, and explore all the ways you can manage it effectively.
Knowledge is power, and we're giving you the power to take charge of your health. All right, let's start with a term you've probably heard a million times: hypertension, or in plain English, high blood pressure. Seems simple enough, right?
You'd think so, but here's the catch. Different health organizations actually have slightly different ways of defining what high really means. It's not as straightforward as you'd imagine.
Okay, so let's break it down organization by organization. First up, the International Diabetes Federation, or IDF. What's their take on high blood pressure?
The IDF, they're pretty specific. They say if your blood pressure clocks in at 130 over 85 millimeters of mercury mmHg for short or higher, well, that's hypertension, as far as they're concerned. But here's another thing. They also consider people who are currently on medication for high blood pressure, even if their numbers look good now.
Interesting. So it's not just about a single reading, it's about your history, too.
Right. If you've been diagnosed with hypertension before and you're taking meds to keep it under control, the IDF still considers you to have hypertension, even if your current reading is below that 138/5 mark.
Makes sense. So what about the World Health Organization, or WHO? Do they see eye to eye with the IDF on this?
The WHO, they set the bar a little higher. For them, it's 140 over 90 millimeters G or greater that qualifies as hypertension.
So a bit more lenient than the IDF. I remember reading about another set of guidelines somewhere. What was that? The cholesterol folks, right?
You got it. The National Cholesterol Education Program, or NCEP, specifically their adult treatment plan, or the third. They go by NCEP ETP3 for short. They're the most cautious of the bunch. They define hypertension as anything 130 over 80 or higher.
Wow, so depending on which guidelines your doctor follows, you could be labeled as having hypertension or not, even with the exact same blood pressure reading. That's pretty wild. It really shows how even one piece of this cardiometabolic puzzle can be super complex. Let's move on to another piece. Dyslipidemia. What exactly does that tongue twister of a word mean?
Basically, it's about having unhealthy levels of fats or lipids in your blood. Think cholesterol, triglycerides, that kind of stuff. And guess what? Just like with hypertension, those good old health organizations have differing opinions on how to diagnose dyslipidemia, too.
Of course they do. Let's start with the IDF again. What are their criteria?
They look at two things: triglycerides and HDL cholesterol. No, the good cholesterol. The IDF says if your triglycerides are 150 milligrams per deciliter or higher, or 1.7 millimoles per liter if you're using the metric system.
Okay, so high triglycerides are a red flag.
Yep, and low HDL cholesterol is the other part of the equation.
What counts as low HDL?
Well, it depends if you're a man or a woman. The IDF considers less than 40 milli-GDL low for men and less than 50 for women.
So for the IDF, it's the combo of high triglycerides and low good cholesterol that spells trouble. What about the WHO? Do they agree?
They're on the same page about the triglycerides, still looking for that 150 milli-GDL or 1.7 millimolars L cutoff. But they're a bit stricter with the HDL. For men, they say anything less than 35 milli-GDL is too low, and for women, it's less than 39.
Wow, so even lower thresholds for the good cholesterol. So many numbers to keep track of. What about the NCPTP3 FEX? Where do they stand on this?
Funny you should ask, they actually use the exact same criteria as the IDF for dyslipidemia. So both IDF and NCEP ATP3 are looking at those same triglyceride and HDL cholesterol numbers.
Okay, so at least there's some agreement somewhere. But still, all these different definitions can make it hard to wrap your head around what really matters for your health. It's like trying to solve a puzzle with pieces from different sets. All right, so now we know how these organizations define hypertension and dyslipidemia. How do we actually find out who's at risk for this whole cardiometabolic syndrome thing?
Well, you got to start with education, right? People need to know what they're dealing with, what those risk factors are, what can happen if it's not managed, and why early detection is so important.
Education is key. And what about actual testing? How do doctors figure out who needs a closer look?
There are a few key tests involved. It usually starts with checking your blood sugar. That could be a simple fasting blood glucose test where you don't eat anything overnight and then they check your sugar levels in the morning. Or there's the HbA1c test, which gives you an average of your blood sugar over the past few months.
So snapshot versus a long-term view.
Exactly. They'll also check your lipid levels. That's a blood test that measures your total cholesterol, your LDL, the bad cholesterol, your HDL, the good one, and your triglycerides.
Got it. And blood pressure, of course, is a must-have.
Absolutely. They'll also ask about your smoking habits because that plays a huge role. And they'll take some basic measurements like your weight and waist circumference to get a sense of your body habitus. Oh, and family history matters too. They'll want to know if you have any relatives with diabetes, heart disease, or high cholesterol.
So it's a pretty comprehensive assessment, like a health detective gathering clues. So let's say someone is flagged as high risk. What's the next step? I know lifestyle changes are a big deal.
Lifestyle is the foundation, no doubt. It's about prevention and management. Two big things stand out: exercise and maintaining a healthy weight.
Let's tackle exercise first. What does it actually do for your heart and metabolism?
Well, for starters, it strengthens your heart and blood vessels, makes them more efficient, improves your overall cardiovascular fitness. It also helps you burn calories and build muscle, which is essential for weight management. And here's a big one. Exercise makes your body more sensitive to insulin, which is critical for preventing and managing type 2 diabetes.
Insulin sensitivity. We talked about that before, with insulin resistance being a problem.
Right, so exercise kind of counteracts that. It helps your body use insulin more effectively, which keeps your blood sugar levels stable. Studies have shown that people who exercise regularly have a much lower risk of developing diabetes in the first place.
Makes sense. Now, let's talk about weight loss. How does shedding those extra pounds help with the whole cardiometabolic picture?
Even losing a small amount of weight can have a big impact. Think 5 to 10% of your starting weight. That can improve your cholesterol levels, increase your good HDL cholesterol, and lower those pesky triglycerides. And just like exercise, weight loss makes you more sensitive to insulin, which helps regulate your blood sugar.
So less weight, less strain on your metabolism.
Exactly. It also lowers your blood pressure and slashes your risk of developing type 2 diabetes.
Amazing how much of a difference a few pounds can make. So what's the magic number when it comes to exercise and weight loss? What are the goals doctors usually recommend?
For exercise, aim for at least 30 minutes of brisk walking or something similar most days of the week. 5 days or more is ideal. As for weight loss, shooting for that 10% reduction is a great starting point.
Sounds achievable. Now let's talk about the elephant in the room, smoking. We all know it's bad. But what's the specific connection to cardiometabolic syndrome?
Smoking, whether you're the one puffing away or just breathing in someone else's smoke, it's a major risk factor for developing cardiometabolic syndrome. And not just in adults, but in kids too. It wreaks havoc on your entire metabolic system.
Seriously, even secondhand smoke can increase your risk.
Yep, it's that bad. It messes with your insulin sensitivity, making it harder for your body to use insulin properly. It also skyrockets your chances of getting macrovascular diseases. Those are the ones that affect your large blood vessels, like peripheral artery disease, which affects blood flow to your limbs, heart attacks, and strokes.
So smoking's a recipe for disaster when it comes to your heart.
It also worsens the complications of diabetes, those that affect the tiny blood vessels in your eyes, kidneys, and nerves. And of course, let's not forget about lung disease.
Okay, so smoking is a hard pass. Whether you're trying to manage cardiometabolic syndrome or prevent it altogether, quitting smoking is a must. Let's talk about blood sugar control now. For people who already have diabetes, how important is it to keep their blood sugar levels in check?
It's absolutely vital, no two ways about it. Research shows that for every 1% increase in your HbA1c, which is that measure of average blood sugar we discussed, you increase your risk of heart attack or stroke by about 18%. And get this, your risk of peripheral artery disease jumps by a whopping 28%.
Those are some scary numbers. So controlling blood sugar isn't just about feeling better, it's about protecting your heart.
Exactly. Studies have shown that people with type 1 and type 2 diabetes who manage their blood sugar well have a significantly lower risk of developing heart problems later on.
So what's the ideal blood sugar level? What are doctors aiming for?
There are a few targets. Your fasting blood sugar, the one you measure first thing in the morning before eating, should be under 110 milligdl. After you eat, your blood sugar, usually measured about 2 hours later, should be under 180 milligdl. And your HbA1c should ideally be below 7%.
So it's a balancing act. But staying within those ranges can really make a difference. What about medications? If someone's struggling with insulin resistance or already has type 2 diabetes, What kind of drugs can help?
There are a few types that work in different ways. One group is called insulin sensitizers. They basically make your body's cells more responsive to insulin, helping it work better. Metformin is a common one, and it belongs to the big one-eyed family. Then you have the PPAR agonists like rusiglitazone and pioglitazone. Those are the glitazones. And there are also the glitazars. Sometimes doctors combine these different types for better blood sugar control.
So it's about giving insulin a helping hand. What about drugs that boost insulin production itself?
Those are called insulin secretagogues. They tell your pancreas to pump out more insulin. The sulfonylureas are the most common ones with names like glipizide, glyburide, and glimepiride. Then there are the meglitinides like ripaglinide.
So many options. It's good to know there are tools available to help manage those blood sugar levels. Let's go back to blood pressure for a minute. We talked about definitions, but why is controlling it so crucial? What does it do for your heart?
High blood pressure is a silent killer, no joke. Decades of research, from massive studies like the MRFIT and the Framingham Heart Study, have proven that sustained high blood pressure significantly increases your risk of all sorts of heart problems, like heart attacks, strokes, and even heart failure.
Those studies are like the cornerstones of heart health research. What did they find about the benefits of keeping your blood pressure under control?
Well, one of the biggest findings was that people who actively treated and managed their high blood pressure had a way lower risk of developing heart disease over time. One study even found that controlling high blood pressure could slash your risk of stroke by about 40%. The idea that blood pressure matters, that's not new. It predates a lot of the research on metabolic syndrome.
Wow, so it's a real game changer. What's the ideal blood pressure number to aim for?
Less than 130 over 80 millimilli HGS. That's the target for most adults, especially if you're concerned about cardiometabolic syndrome. Hitting and staying within that range, that's a big win for your heart health.
Funny enough, that's the same number the NCEP-ATP3 uses to define hypertension in the first place. Okay, let's switch gears to lipid control. We talked about what dyslipidemia is, but why is it so important to keep those cholesterol and triglyceride levels in check?
Think of it this way. High LDL cholesterol and triglycerides, along with low HDL cholesterol, they're like little troublemakers that pave the way for atherosclerosis. That's where plaque builds up inside your arteries, making them narrow and stiff, eventually leading to heart attacks and strokes. Tons of studies have shown that taking medications like statins and fibrates to control those lipid levels can dramatically lower your risk of heart problems. We're talking reductions of 24% to 37% in some cases.
That's a huge improvement. So just like with blood sugar and blood pressure, there are target numbers for cholesterol and triglycerides too.
Absolutely. For LDL cholesterol, the goal is usually under 100 milligdl or under 3.0 milligdl. If you're at high risk, they might even want it under 70 milligdl or 2.6 milligdl. Triglycerides, you want those below 150 milligdl or 1.7 millidol. And for HDL, aim for over 40 milligdl or 1.1 milligdl.
So it's a multi-pronged approach. Lower the bad stuff, raise the good stuff. You mentioned statins and fibrates for lipids. What about medications for high blood pressure?
There's a whole arsenal for that. You've got your ACE inhibitors and ARBs. Those work by relaxing your blood vessels. Then there are diuretics, calcium channel blockers, beta blockers, alpha blockers, and even a central-acting alpha agonist called moxolidin. The choice really depends on the individual and their overall health.
Wow, lots of options there. What about drugs specifically for dyslipidemia?
Statins are the stars of the show. They're really effective at lowering LDL cholesterol, often the first line of defense. Fibrates are great for tackling high triglycerides and can also give your good HDL cholesterol a boost. Niacin, which is actually vitamin B3, can help too, but it has more side effects, so it's not as commonly prescribed.
And what about those platelet inhibitors I read about? Aspirin, clopidogrel, that kind of thing. What role do they play in all of this?
Platelet inhibitors like low-dose aspirin and clopidogrel, they're blood thinners, essentially. They prevent blood clots from forming. Doctors might prescribe them to people at high risk of heart attack or stroke, especially if they've already had one, or if they have diabetes or other risk factors. It's all about preventing those dangerous clots.
So it's another layer of protection for your heart. Now, we've been talking about metabolic syndrome this whole time, but I noticed some experts are actually questioning whether it's a real syndrome at all. What's the deal with that?
It's a debate, for sure. Organizations like the American Diabetes Association, or ADA, and the European Association for the Study of Diabetes, or EASD, they're arguing that the term metabolic syndrome might be a bit misleading. They say it doesn't really tell us anything more than we already know from looking at each individual risk factor.
So it's not that these risk factors aren't important. It's that lumping them together under this syndrome label might not be that helpful.
Right.
One issue is that there's no clear single cause for metabolic syndrome. Insulin resistance is thought to be involved, but it's not always present, and it might not explain everything. Plus, the risk of heart disease in people diagnosed with metabolic syndrome isn't necessarily higher than what you'd expect based on their individual risk factors alone.
So knowing someone has high blood pressure, high cholesterol, and high blood sugar might be just as informative as saying they have metabolic syndrome.
Exactly. That's why the EDA and the EASD are saying, hey, let's focus on treating each risk factor on its own, regardless of whether someone meets the criteria for metabolic syndrome or not. Treat the high blood pressure, manage the cholesterol, control the blood sugar, and of course, push those lifestyle changes, especially for people who are overweight or obese.
Seems like a more practical approach.
Well,
Now, I came across a study that looked at specific metabolic abnormalities in the Qatari population. They found some interesting differences between men and women. Oh, yeah, that study. They looked at a bunch of men and women in Qatar and saw how common those NCP ATP3 risk factors were in each group. One big finding was that abdominal obesity, measured by waist circumference, was way more common in women. Almost 75% of women in the study had it compared to just 56% of men.
wow, that's a huge gap. Were there other differences between the sexes?
Diabetes was also more common in women, around 26% compared to 19% in men. But when it came to high triglycerides, men took the lead. Almost 28% of men had high triglycerides versus 20% of women. Hypertension and low HDL cholesterol were pretty similar between men and women, though women had slightly lower HDL, but that difference wasn't statistically significant.
So different risk factors seem to be more prevalent in each sex. Did they also look at how many of these risk factors people had in total? Like how many pieces of the puzzle were there?
They did. They found that roughly the same percentage of men and women had none of the risk factors, but having one risk factor was slightly more common in men. Having two was similar for both sexes. But then things shifted. Having three or more risk factors, that was way more common in women, almost 31% compared to 22% in men.
So women were more likely to have a cluster of risk factors, even if the specific risks varied. That's what metabolic syndrome is all about, right? This clustering of issues.
Right. They also did a fancy statistical analysis to see which factors were independently linked to metabolic syndrome. They found that age was a big one. Each year older you are, the higher your odds of having metabolic syndrome. Being female was also a risk factor, even after accounting for other things.
So being a woman increases your chances of having metabolic syndrome independently of other factors. What else did they find?
BMI, unsurprisingly, played a role. Higher BMI, higher risk. Family history of diabetes also increased the odds, and one of the strongest links was smoking. Smokers had over 3 times the odds of having metabolic syndrome compared to non-smokers, even after adjusting for age, gender, and BMI.
It's crazy how much smoking can affect your health.
Yep.
Okay, let's zoom out a bit and look at the global picture. How common is metabolic syndrome in different countries? I imagine it varies quite a bit.
It does, and it's not just about geography, it's also about how they define metabolic syndrome in each study. Even the age and characteristics of the population matter. Plus, lifestyle, diet, and genetics, they all play a role. For instance, in Arab Americans, they found a prevalence of about 23%. In Oman, it was 21%, but in Jordan, it jumped to 36%.
Wow, a big range even within one region. What about the rest of the world?
Well, in the US, they reported about 34%. In Greece, it was lower, around 21%. South Australia was even lower at 15%. Then you have South Korea with a really low prevalence of just 6.8%. China was 10.2%. Turkey popped up again with 33.4%. Chennai in India had a whopping 41%. And Qatar was there too at 27.6%. It's a real mixed bag.
It really shows how complex this issue is. It's not just one thing, it's a web of factors. Now, let's talk about the big picture, the CVD epidemic, especially in developing countries. What are some of the trends and challenges there?
There's a lot to unpack. One concerning trend is the high rate of heart disease in people of South Asian descent. And what's interesting is that their traditional risk factors, like smoking and cholesterol, don't fully explain it. They also have a high prevalence of diabetes and glucose intolerance.
Are there any physical characteristics or metabolic patterns common in South Asians that might shed some light on this increased risk?
Yeah, many of them have this combination of central obesity, high triglycerides, and low good cholesterol, sometimes with glucose intolerance, too. There's a thought that genetics might make them prone to having high lipoprotein, which is a type of cholesterol, and that this cluster of issues might be linked to their higher risk of heart disease.
So genes might be loading the gun, so to speak. And then you have environmental factors pulling the trigger.
It's a combination, for sure. Environmental changes can amplify those genetic risks. There's this idea of the thrifty gene hypothesis, which basically says that some genes that helped our ancestors survive famines might now be making us more susceptible to obesity and diabetes in a world with abundant food.
It's like our genes haven't caught up to our modern lifestyle.
Exactly. And then you have the differences between urban and rural environments. Urban areas in developing countries often have higher rates of obesity, hypertension, dyslipidemia, and diabetes, probably due to more sedentary lifestyles and those processed food diets. Meanwhile, smoking might be more common in rural areas.
So the type of risk might depend on where you live. What about socioeconomic factors? Do they play a role?
It's complex. Initially, heart disease might be more common in wealthier populations who have adopted those westernized lifestyles. But as the epidemic progresses, poorer communities become more vulnerable. They might have limited access to healthy food, safe places to exercise, and quality health care. It's a worrying trend that could worsen existing health inequalities.
And then you have countries like Pakistan, where it's tough to even assess the true burden of CVD. What are the challenges there?
Data collection is a major hurdle. Their death certificates might not be accurate or specific enough. Often they'll list multiple causes of death, which makes it difficult to pinpoint CVD as the primary cause. It's hard to get a clear picture without reliable data.
Data is everything when it comes to understanding and tackling these health challenges. Let's talk about the IDF again. They came up with a new definition for metabolic syndrome, right?
Yeah.
What are their goals with that?
They wanted a definition that was more useful, both for doctors and researchers. They wanted to identify people at higher risk of both heart disease and diabetes. They wanted something doctors could use easily in their practice. And they wanted a definition that would work globally so researchers could compare data from different countries.
Makes sense. So what's different about their definition? What makes it stand out?
They made central obesity, measured by waist circumference, a mandatory criterion. It's not just about insulin resistance anymore. You have to have that belly fat, plus at least two other metabolic abnormalities.
Okay, so a big belly is a non-negotiable red flag, according to the IDF. And what are those other abnormalities they're looking at?
They have a list of 4. High triglycerides, low good cholesterol, high blood pressure, and high fasting blood sugar. If you have central obesity plus any 2 of those, that's metabolic syndrome, according to the IDF.
So it's a combination of factors, with central obesity being the key. We talked about the importance of exercise. But why do so many people struggle to be active even when they know it's good for them?
It's complicated. Some people just aren't aware of the full benefits. They might not realize how much exercise can impact their weight, their heart health, and even their risk of chronic diseases like diabetes and cancer. Social and cultural norms can also play a role, sometimes discouraging exercise, especially for women.
It's like those unwritten rules that can hold people back.
Then there's the environment. If you don't have access to safe parks, walking trails, or affordable gyms, it's harder to be active. And let's not forget about our modern lifestyle. We're all glued to screens, sitting in cars, and not moving as much as we used to. It's a recipe for inactivity.
It's like modern life is working against our health in some ways. We've talked a lot about insulin resistance. It's a key player in diabetes, but what else is it linked to?
Insulin resistance is like a spider web connected to a bunch of health problems. We already talked about type 2 diabetes and impaired glucose tolerance, but it's also linked to obesity, especially that abdominal obesity.
Yeah.
High blood pressure and high cholesterol are in the mix too.
So it's like a domino effect. One thing leads to another.
Exactly. In women, insulin resistance is often seen in polycystic ovary syndrome, or PCOS. It can also contribute to high uric acid levels, a skin condition called acanthosis nigricans, and problems with blood clotting. And of course, it plays a big role in the development of atherosclerosis, which is the root of most heart problems.
So insulin resistance is a real troublemaker. It's amazing how much one thing can impact so many different systems in your body. Now, you mentioned a U.S. study on metabolic syndrome. What did that one show?
That was the NAS study, a big one. They collected data from thousands of adults in the U.S. and found that metabolic syndrome becomes more common as people age. When they compared the IDF and NCE definitions, the NCEP1 found a prevalence of about 34% in men and 35% in women. The IDF definition was a bit higher for men, almost 40%, and slightly lower for women, around 38%.
So once again, the definition you use can change the numbers. We've covered a lot of ground here. What's the bottom line when it comes to the risk of dying from heart disease and the number of metabolic syndrome risk factors you have?
The evidence is clear. The more risk factors you have, the higher your risk of dying from heart disease. They look at something called the hazard ratio. If you have none of the risk factors, your baseline risk is 1. If you have 1 or 2 risk factors, that ratio and your risk goes up. But if you meet the criteria for metabolic syndrome, your risk jumps even higher. And if you have metabolic syndrome plus type 2 diabetes, it's even worse.
So it's like stacking blocks. Each risk factor adds another layer of danger. It's a powerful message. Even if you don't have a full-blown diagnosis, those individual risk factors still matter. So what can we do to prevent this whole mess?
Prevention is key. We need more research to fully understand how these metabolic problems work and to develop better ways to stop them before they start. We also need to educate people about the risks and how to make healthier choices. And we need to take what we've learned in developed countries and adapt it for developing countries, considering their unique challenges. Prevention is the best medicine, but the question is, do we know enough yet to truly prevent this global epidemic?
It's a journey, and we're still learning. I remember seeing a diagram that used puzzle pieces to explain the treatment for metabolic syndrome. What was the gist of that?
That diagram showed the different pieces of the treatment puzzle all fitting together. At the center, the most important piece was lifestyle change. Diet, exercise, that whole package. Then you had other pieces like quitting smoking, taking medications for diabetes, high cholesterol, and high blood pressure. They even included those CB1 receptor blockers, though they're not used as much anymore. The idea was that it's a multi-pronged approach, tackling different aspects of the syndrome simultaneously.
It's not about finding one magic pill, it's about addressing the whole picture. So what are the main recommendations for treating metabolic syndrome?
First and foremost, lifestyle changes are the foundation. That means eating a healthy diet, being physically active, and managing your weight. Specifically, aiming for a 5 to 10% weight loss in the first year is a good goal. But it's important to be realistic. Lifestyle changes are hard to stick to long term.
It's a marathon, not a sprint.
Absolutely. So medication often becomes necessary to control blood sugar, blood pressure, and cholesterol levels. The goal is to choose medications that have broad benefits, not just targeting one thing, but addressing multiple aspects of the syndrome.
Smart approach. So the IDF definition, it was designed to be helpful for both doctors and researchers. Can you sum up its key advantages?
Sure, it gives doctors a simple way to diagnose metabolic syndrome in their practice. It's a tool they can use globally while considering ethnic differences in body fat. And for researchers, it provides a more standardized set of criteria for their studies, which helps when comparing data from different populations.
So it's practical and scientifically sound.
Yeah.
Now, one last thing, measuring waist circumference. It's a key part of the IDF definition. How do you do it right?
It's pretty straightforward. Find the top of your hip bone, that's the iliac crest. Wrap a measuring tape around your bare waist at that level. Make sure the tape is snug but not too tight, and it should be parallel to the floor. Take the measurement at the end of a normal exhale, not holding your breath. Generally, if your waist is over 35 inches for women or 40 inches for men, that's a sign of increased risk. But those numbers can vary depending on your ethnicity and age, so check with your doctor.
Simple but important. And lastly, I remember those impressive stats about how much even a small improvement in blood sugar control can do.
Yeah, a 1% drop in HbA1c, which you can achieve through lifestyle changes, can significantly reduce your risk of diabetes complications. We're talking 21% lower risk overall, 37% lower risk of problems with your eyes, kidneys, and nerves, and even a 14% lower risk of heart attack. But let's be real, sticking to those lifestyle changes long term, it's tough. That's why many people with diabetes eventually need medication to help manage their blood sugar and prevent those complications.
So lifestyle is the foundation, but medication can be a necessary support.
That's the reality.
Well, we've explored a lot today, from the different definitions of cardiometabolic syndrome to the individual risk factors, the global trends, and the importance of both lifestyle changes and medications. We've really delved into this complex and interconnected web of health issues.
We hope this deep dive has given you a clearer understanding of this crucial topic, empowering you to have more informed conversations with your healthcare providers and make proactive choices for your well-being.
Now, here's a final thought to chew on. We know these risk factors are all linked. So what's one small manageable change you can make in your life, starting today, that could have a ripple effect on your overall cardiometabolic health? That's your homework, folks. Think about it, explore it, and take charge of your health.